Today's material is a comprehensive collection of medical notes, diagnostic algorithms, and clinical case studies covering endocrine pathology, aimed at preparing students for the USMLE exams. But we need to pivot immediately to the structure, because I just want to briefly summarize how this source material is currently organized.
Yeah, let's do it.
It jumps directly from basic anatomical mnemonics, like the adrenal cortex layers. The deeper you go, the sweeter it gets. Straight into these incredibly complex clinical management scenarios, like the rapid ACTH stimulation test or aggressive fluid resuscitation for an Addisonian crisis. So how does this impact the reader's cognitive load?
Well, the current arrangement of the content merges foundational principles and advanced clinical management without clearly distinguishing the knowledge required for different stages of medical training.
Right. It's just all mashed together.
Exactly. It abruptly shifts from basic USMLE Step 1 concepts directly into Step 2 and Step 3 diagnostic and management algorithms, and there's just no clear progression.
It's kind of jarring, honestly.
It really is. For example, jumping from the genetic mutations of Carney complex, specifically the PRKA1A mutation, right into the fluid replacement strategies for an acute adrenal crisis. It creates this really disjointed learning experience.
Because you're going from cellular genetics to the ICU ward in one paragraph.
Right, exactly. It forces the reader to constantly switch contexts between foundational science and advanced clinical ward management. The brain just isn't designed to pivot like that seamlessly.
But wait, hold on. I want to push back on this a little bit. Isn't there a benefit to this kind of, holistic vertical integration? If a student is learning about the adrenal gland, shouldn't they see the whole picture from anatomy to treatment in one place?
I get that instinct, I do. But while vertical integration is good, the material needs explicit tiering.
Okay, tiering. How so?
Basically, you need to restructure the modules into a clear, stepwise progression that explicitly aligns with the USMLE Step 1, 2, and 3 frameworks. You have to use visual or structural markers to guide the learner.
Oh, so they know exactly what phase of their training they're reading about.
Right. So for concrete examples, you'd start an adrenal module with the Step 1 foundational pathophysiology.
Like the layers of the cortex?
Exactly. The layers, cortisol's effect on gluconeogenesis, and the genetics of microadenomas. Keep it purely Step 1. Then you create a distinct Step 2 clinical diagnosis subsection.
Okay, so that would focus on the clinical presentation and workup.
Yeah, like the sequence of testing for Cushing's. You do the 24-hour urine-free cortisol, then the late-night salivary cortisol, and the low-dose dexamethasone suppression test.
Right. Moving from the cell to the lab.
Exactly. And then you conclude with a Step 3 clinical management subsection that details exact treatments.
So that's where the specific IV hydrocortisone bolus and infusion rates for an Addisonian crisis would live?
You got it. And emphasize that this is just one way to restructure, but the primary goal is to map the content to the reader's specific exam milestones.
Yeah, that makes a ton of sense. So now that we've established the need to organize this material by the appropriate clinical steps, we need to look at the internal logic of the content itself, specifically how the foundational sciences in Step 1 support the clinical presentations in Step 2.
Right, the transition from mechanism to symptom.
Exactly. Because I noticed the material contains a lot of these really dense clinical flashcards, like the 52-year-old male with long-standing diabetes who develops claudication and sensory loss, or the primary hyperparathyroidism presentation of stones, bones, and groans. How do you think the material handles the why behind these symptoms?
Well, a vital opportunity exists to strengthen the connective tissue between underlying pathophysiological mechanisms and their corresponding clinical presentations.
Because right now, that connective tissue feels kind of flimsy.
It really does. The material frequently lists clinical findings or lab results alongside a disease without explicitly explaining the mechanism causing the symptom. And that is a critical requirement for USMLE-style questions.
Give me an example of where it falls short.
Sure. So, for instance, the flashcards mention that hypercalcemia causes peptic ulcer disease and acute pancreatitis. But they merely drop these brief parentheticals, like calcium stimulates gastrin.
Right, I saw that. Just a few words in brackets?
Yeah, and it doesn't integrate this into the core pathophysiological narrative. It's just rote memorization.
But let me ask you this. If the reader is using this for rapid review, is there a risk that adding too much physiological explanation will sort of dilute the high-yield facts, like make the flashcards too dense?
I mean, I see where you're coming from, but memorization without mechanism leads to poor performance on board exams. It just does. You have to explicitly integrate the pathophysiological bridge directly into the clinical case discussions or the flashcard answers. Keep it concise, but it has to be complete.
Okay, so how do we do that practically? What's a concrete way to fix that diabetes neuropathy case, for example?
Okay, so in that diabetes neuropathy case, instead of just stating sorbitol accumulation from autonomic neuropathy, you explicitly map out the intracellular aldose reductase pathway.
Ah, right. Building the actual mechanism out,
Exactly. You explain how the depletion of NAPDH causes oxidative stress.
which then directly links to the stocking glove sensory loss presented in the vignette.
Exactly. You're telling a biological story. Or look at the hyperparathyroidism section. You need to expand on exactly how hypercalcemia alters the renal tubular concentrating ability.
Right, because that's what causes the nephrogenic diabetes insipidus.
Yes, which links the elevated calcium directly to the symptom of polyuria.
Oh, wow. Yeah, that makes the symptoms so much easier to remember because you understand the engine driving it.
Right, and remind the listener that these are just a few examples of how to weave the why into the what. You should be doing this throughout the entire document.
Okay, so once a student understands the mechanism behind the symptoms, they need to execute a diagnostic workup, which brings us to how the diagnostic pathways are presented in these notes.
Yeah, this is a big one.
I mean, just to summarize how the diagnostic criteria are currently formatted, it's a bit chaotic. For example, the criteria for diagnosing diabetes mellitus are scattered across multiple tables. You've got fasting glucose less than 100 versus greater than 126 in one spot, OGT criteria somewhere else, HbA1c on another page.
It's everywhere.
And the workup for Cushing's syndrome is split between text lists, a chart on diurnal rhythm, and then a really complex flowchart.
Right. So the diagnostic pathways, particularly for complex endocrine syndromes, are currently presented as fragmented tables and separate text blocks, rather than cohesive, stepwise clinical algorithms.
Which feels like it defeats the purpose of an algorithm entirely.
It really does. Having diagnostic criteria spread across different formats makes it incredibly difficult for a test taker to memorize the exact sequential algorithm required for USMLE Step 2 and 3 questions.
Because the boards love those what is the next best step in management questions.
Exactly. And when a student is asked that, they need a mental flowchart. They do not need a scattered list of equivalent tests. They need to know exactly what to do first, second, and third.
Okay, but let me play devil's advocate for a second. Medicine isn't always a perfect flowchart, right? Doesn't standardizing everything into a rigid tree run the risk of oversimplifying atypical cases?
Like what kind of cases?
Well, like the atypical Cushing's presentation mentioned in the notes, the ones with near-normal 24-hour UFC. If we just give them a rigid flowchart, aren't we glossing over the nuance?
It's a fair point, and I acknowledge the nuance. But for USMLE preparation, a baseline standard algorithm must be established first before introducing exceptions. You have to synthesize these fragmented diagnostic criteria into unified, standardized clinical decision trees.
So build the rules before you teach the exceptions.
Precisely. You need a tree that guides the learner step by step from initial suspicion to definitive diagnosis.
Do we have a concrete example of a good tree in the material already?
We actually do. You can use the highly effective polyuria and polydipsia flowchart provided in the source material. It elegantly walks through urine osmolality, water deprivation tests, and DDAVP administration. Use that as the gold standard template for the rest of the document.
Oh yeah, that chart is fantastic. So we just build a similar unified decision tree for Cushing's.
Exactly. Step 1. Confirm hypercortisolism with a 24-hour UFC, late-night salivary, or low-dose DST.
Right.
Step 2. Check ACTH to distinguish ACTH-dependent versus independent.
And then step 3?
Right. Step 3. High-dose DST or CRH stimulation to differentiate pituitary from ectopic sources.
Okay, but where do we put those atypical cases we talked about?
You place atypical presentations like the cyclical hypercortisolism as specific, clearly marked clinical pearls branching off the main algorithm.
Oh, so they're attached to the flowchart, just sort of visually distinct?
Exactly. So the baseline is clear, but the nuance is right there when they're ready for it.
That is a fantastic way to organize it. All right, let's briefly recap the actionable suggestions we've covered in this critique. First, restructure the content into explicit tiers mapping to USMLE Steps 1, 2, and 3. Second, strengthen the bridges between foundational pathophysiology and clinical symptoms in those flashcards. And third, synthesize the scattered diagnostic tests into unified step-by-step clinical algorithms.
Yeah, if they do that, it'll make a world of difference.
We invite the listener to implement these changes and submit the revised material back for another critique.